DUP is duration of untreated psychosis. Think of the brain on fire. The longer the fire burns before you put it out, the more damage it does. When someone first hears voices or has a strange belief, that is day 0. If they get medication by day 14, that is a 2-week DUP. If they get medication at month 6, that is a 6-month DUP. The research is absolutely clear. Shorter DUP leads to faster recovery, better cognitive function, and better long-term life outcomes. The brain is neuroplastic, it rewires itself. During untreated psychosis, it rewires in the wrong direction. Once treatment starts, it can rewire in the right direction. But the sooner you start, the less damage has already been done. Every day matters, every week matters. NICE, National Institute for Health and Care Excellence, is the gold standard for clinical guidelines. They reviewed all the research and said, you need to treat first episode psychosis within 2 weeks. Not within 2 weeks of the referral. Not within 2 weeks of first seeing a psychiatrist. Within 2 weeks of when the person first started experiencing psychotic symptoms. This is grade A evidence, the strongest level. It is based on dozens of randomized controlled trials showing that people treated early do much, much better. Why 2 weeks specifically? Because that is the window where the brain is most responsive, where you can still prevent most of the neurological damage, where early treatment makes the biggest difference. EIP stands for Early Intervention in Psychosis. These are not regular psychiatric clinics. These are specialist teams built for first episode psychosis. Why specialist? Because first episode psychosis needs different skills than general psychiatry. You need psychologists trained in CBTp, therapy specific for psychosis. You need case managers who do outreach. You need peer supporters who have recovered from psychosis. You need psychiatrists who specialize in early psychosis. The key feature: they respond to crises within 48 hours, not weeks. Within 2 days, this helps achieve that 2-week DUP target. They typically follow someone for 2 to 3 years, that is time limited. The goal is recovery and independence, not lifelong psychiatric care. Early intervention has 4 clear goals. Let me go through them. Goal 1, get diagnosed fast and accurately, not maybe psychosis. Know what you are treating. Goal 2, get treatment started, minimize DUP. This is why EIP teams exist. Goal 3, keep the person in their life, keep them in school, at work, with their friends and family. Early treatment makes this possible. Untreated psychosis destroys all of this within weeks. Goal 4, prevent long-term disability. With early intervention, many people fully recover. They do not have to have their lives derailed by schizophrenia. The outcomes prove it works. 60 to 80% of people achieve remission. Their brains are protected. They keep their jobs or finish school. Their relationships survive. They have quality of life. This is why we push so hard for early intervention. The acute phase is chaos. The person is actively psychotic. They are hearing voices, believing false things, paranoid, disorganized. They might not have slept in days. Your job is not subtle psychopharmacology. Your job is emergency management. Like an doctor treating a heart attack, you do not worry about future diabetes risk. You worry about stopping the heart attack. In acute phase, you have 4 jobs: keep them safe, prevent harm to self or others, stabilize the acute symptoms, figure out if standard treatment will work or if they are treatment resistant, and start building a therapeutic relationship. The acute phase lasts 6 to 12 weeks. By the end, you should have a much calmer patient with improving symptoms. NICE says, use one of these 4 drugs first. These are the best evidence, proven to work, well tolerated for most people. Risperidone is the workhorse. Works well, moderate side effects, widely used. Olanzapine is very effective but causes weight gain. Use if patient is thin or very acutely psychotic. Quetiapine is very sedating. Use when sedation is therapeutic. Patient is agitated and not sleeping. Aripiprazole is the newest. Minimal weight gain, minimal metabolic problems. Good if you're worried about long-term side effects. All 4 work. The question is which one is right for this patient with their situation. Here is the most important principle. Start low, titrate slowly. Do not throw maximum doses at the patient. Start 2 mg of risperidone, not 6 mg. Start 5 mg of olanzapine, not 15 mg, then increase slowly over 2 to 3 weeks. Why? Because slow titration means the patient tolerates it better. They have fewer side effects. They are more likely to take the medication. And you get the same efficacy anyway. There is no benefit to loading doses. The neurobiology, you need about 65 to 80% dopamine D2 occupancy for maximum effect. Above that, you do not get more benefit. You just get more side effects. Slow titration also lets you find the right dose for this patient. Some need 4 mg, others need 8 mg. You find out by titrating carefully. You cannot just start medication and disappear. You need to monitor actively. At week 2, you check in. Is the patient calmer? Are they sleeping? Are side effects manageable? These are early signs that medication is having effect. At week 4, you assess symptom response. Are the hallucinations decreasing? Are the delusions less prominent? Is the person more reality-oriented? This is when you really see if the medication is working. At week 6, you make a decision. Is this medication working well enough? If yes, continue and move toward maintenance. If no response, you consider switching to a different antipsychotic. Do not give up after 2 weeks. Do not jump to switching after 3 weeks. Give real adequate trial 4 to 6 weeks at a therapeutic dose before concluding it does not work. Before you give even 1 dose of antipsychotic, you must establish baseline. This is not optional. Why? Because antipsychotics affect metabolism. Weight gain happens, blood sugar problems can develop, cholesterol can rise, prolactin can elevate. You need to know the starting point. Weight, you will check this regularly. Baseline matters. Glucose and lipids. Some antipsychotics cause metabolic problems. Baseline determines if something changed or was already there. Prolactin. Important to know baseline because elevation causes sexual dysfunction, which ruins adherence. Blood pressure. Some antipsychotics can cause orthostasis, drop in BP when standing. Baseline helps identify this. ECG measures QTc interval. Some antipsychotics prolong it. Baseline QTc is essential for monitoring. Getting baseline labs is not extra work, it is essential medicine. This is fundamental neurobiology. Antipsychotics work by blocking dopamine D2 receptors, but it is not like more blocking equals more effect. It is a threshold. Below about 60% occupancy, nothing happens. At 65 to 80% occupancy, you get maximum effect. Above 80% occupancy, you do not get more effect. You just get more side effects. This is why slow titration works. You do not need huge doses. You need enough to get to 65 to 80% occupancy. Then you stop. Adding more medication does not help. This explains why Maudsley recommends moderate doses, not maximum doses. You are aiming for the therapeutic window, not trying to block 100% of dopamine. Understanding this changes how you prescribe. You are not chasing maximum doses. You are finding the minimum dose that gets you to therapeutic occupancy. Some patients do not respond to standard antipsychotics. This is treatment-resistant schizophrenia or TRS. Definition: you tried at least 2 different antipsychotics at real therapeutic doses for real adequate time 4 to 6 weeks minimum, and both failed. Important: adequate doses at adequate time, not gave low doses for 2 weeks. Real therapeutic doses for real 4 to 6 week trials. About 30 to 40% of people with schizophrenia have TRS. It is common. If you have TRS, Clozapine is your answer. It works in 60% of people who failed other drugs. That is remarkable. 6 out of 10 people who exhausted other options respond to Clozapine. Clozapine requires intensive monitoring because of a granulocytosis risk, but for TRS the benefits outweigh the risks. Clozapine is powerful but requires careful monitoring because of a granulocytosis. Your white blood cells drop dangerously low. Dosing: start very low, 12.5 to 25 milligrams, then increase slowly. Why? Because Clozapine can cause seizures, especially at higher doses. Slow titration reduces seizure risk. Therapeutic dose range 200 to 450 milligrams daily. Most people respond in this range. Monitoring: this is not optional. This is mandatory. Weekly FBC, full blood count for first 18 weeks, fortnightly for weeks 18 to 52, monthly thereafter for as long as the patient takes Clozapine. Why so intensive? A granulocytosis happens in less than 1% of patients, but if it happens and you are not catching it with blood tests, the patient gets deadly infections. They can die, but if you catch it with blood tests, it is reversible. The patient stops Clozapine, the white counts recover, they live. WBC danger zone: less than 2.0 times 10 to the 9 per liter, or neutrophils less than 1.5 times 10 to the 9 per liter equals stop Clozapine immediately. This is why Clozapine is last line, but it is the most effective for TRS. Here is the truth that some psychiatrists forget: medication alone is not sufficient. Pills treat symptoms, but people need more than symptom relief. The data is clear. Medication alone gets 50 to 60% of people better. That is a coin flip. Add cognitive behavioral therapy for psychosis, CBTp, therapy designed specifically for psychotic symptoms, and you get 70 to 80%. Now most people are getting better. Add family support, employment support, peer support, and you get 85 to 90%. Nearly everyone gets better. NICE says all patients with schizophrenia should receive CBTp. It is not optional, it is part of standard treatment. So do not prescribe antipsychotics and send them home. Give them the whole package. CBTp is not regular cognitive therapy you use for depression. It is specific to psychosis. With hallucinations, the person hears voices. You do not argue or deny them. You validate the experience while exploring alternatives. You help develop coping strategies, headphones, talking back to voices, reality testing techniques. With delusions, the person believes the government is poisoning them. You do not say, "That is crazy." You say, "I understand you believe that. Let us examine the evidence together." You gently explore reality without being confrontational. The techniques work because they teach people to live with and manage psychotic symptoms without being controlled by them. 10 to 20 sessions over 6 to 9 months. About 1 session per week. Not lifetime therapy, not brief intervention. Structured, time-limited, evidence-based. Families need to understand schizophrenia. When they understand the illness, when they support recovery, when they communicate without high criticism or expressed emotion, relapse rates drop by 20 to 40%. This is not just talk to the family, it is specific psychoeducation. Teach them what schizophrenia is, how to recognize early warning signs, how to communicate supportively, how to reduce stress that triggers relapse. High expressed emotion, high criticism, high hostility, high intrusiveness increases relapse. Low expressed emotion, warm, supportive, appropriate boundaries decreases relapse. Families are not the problem, they are the solution, but they need training. Recovery from schizophrenia is not just symptom relief. It is getting your life back, supported employment. Help people get and keep jobs, not just here is a job. Ongoing support, coaching, job coaching, employer liaison, problem solving when problems arise, peer support. People who have recovered from psychosis supporting others, incredibly powerful, reduces isolation, provides hope, teaches practical coping, case management, someone coordinates all the services, ensures the person keeps appointments, resolves barriers, social recovery, getting back to school, getting a job, having relationships, living independently. This is real recovery. These are not luxuries, these are evidence-based interventions that change outcomes.